Okay, hello. How are you all? So today I'm going to go over mastoidectomy and facial nerve identification, and then we'll also cover a little bit of posterior tympanotomy because this is very important for chronic ear surgery and cholesteatoma surgery. I'm going to begin with the cadaver dissection, and then I will show some films afterwards because it won't take us the whole time to do the cadaver dissection. So first thing, actually, it's important to show this also. Look, you see these eye cups. It's very important to understand how to use these eye cups. You should be zeroed on your eyepieces, and the eye cups should be closed all the way if you're using glasses, okay? Not sticking out. If they're used sticking out, they're for blocking the ambient light. But if you wear glasses, then you significantly impair your visibility. So the first thing you do is make sure your microscope is zeroed and set up properly, because otherwise you're going to have a hard time. Good. So I think we see nicely. Let me get that. Let me get this under focus. Good. And my focus is, let me see here, my focus. Okay, let me just get all set up. Good. Now, I'm going to show you basically my way. There are many ways to do things, but my way is specific. Let me take a gauze. So first I begin with incision. The important thing also, I usually do not use a knife. I usually use an electrocautery, but we don't have electrocautery now. So you have to imagine that I'm using an electrocautery. And the reason I use an electrocautery is to try to minimize the blood around the area. There's no concern about using an electrocautery. The wounds heal very, very nicely regardless. Okay, so the first thing, we want to feel the mastoid tip, especially in children. You know, at around 6 years of age, the tip is fully descended to cover. But earlier than 6 years of age, we have to be concerned about superficial facial nerves. So you want to put your finger on the mastoid tip to ensure, and then I mark myself the incision with a pen. And you don't want to be right in the crease. The idea of disguising the incision in the crease only sets you up for a situation where when you try to close it, you can get a nasty scar right in the crease. So you want to be a little bit behind, just under a centimeter behind, so that you have a nice even wound closure, okay? So I'm just going to mark it here. And you want to come up, and you want to curve up into the temporal area, up here, okay? So it's still hidden, but it's high up enough. Then I take a gauze, I put my finger in the external auditory canal, so I know exactly the position of the external auditory canal, and then I hold the ear back with the gauze. Now, with an electrocautery, well, we won't have bleeding here, but you can imagine we're going to go right down, and I do not use a palvoflap. The palvoflap is useful when you're planning a mastoid obliteration or open cavity techniques. But for basic intact canal wall surgery, it's actually best not to use a palvoflap. And the palvoflap, because if you use a palvoflap, you actually cause a little bit of disruption of the structures that you want to see. So now I have my finger in the ear canal, and I have my thumb on the external ear, and I'm pulling this forward very firmly, and I'm taking, this would be with the electrocautery, I'm going in this, what we call this fool's fascia, or this temporoparietal fascia, you see, and I'm dissecting it over the temporalis muscle, right? And I feel my target. So my target is to not cut into the external auditory canal. So by having my finger there, I know exactly where I need to go without visualizing it. So I take this again. The gauze helps you hold the tissue nicely taut. And then, now that I've exposed this area with my finger in the ear canal, I will go straight down to the bone and make one cut this way, and then the second cut this way, directly down to the bone. Okay, just like that. Now, I'm just going to free this up a little bit here, and then I'll show you how with a finger, with this finger now, we can elevate this in one move, okay? So one move will open this up nicely, and we're exactly where we need to be. If you do it like this, you will be very unlikely to get that awful bleeding up in this area, because this incision is directly above the external auditory canal. Okay, so now I can open this up a little bit more, okay, and then here I can open this up a little more to get this nicely down into the ear canal. And we've got the mastoid nicely exposed. We will make a back cut here, but I'm not going to do it right now. I'm going to do it a little after, because when you make the back cut, you lose some of the stability of your placement of your retractor. So let's put the retractor in and hold things forward nicely. Now, I'm going to show you some important aspects of getting into the external auditory canal. Right here, you have the tympanomastoid suture line. And oftentimes, you will see surgeons operate and not properly expose this area, resulting in a very narrow tunnel in which they're working. So the first thing you want to do is you want to take a 15 blade, just like this, place it along the tympanic portion, the mastoid bone, and feel for the suture line. Okay, until you feel the suture line right there. I'm feeling the suture line, and then you want to cut this way. Okay, along the suture line. Hold on. And if it bleeds, and it usually will, you can bipolar it. Okay, the facial nerve is nicely protected and out of the way with the soft tissue. So here is the suture line. See, so it came right off here, and you want to get this nicely open. This would be a vessel here, and this would bleed. Okay, so you can bipolar that. Get this nicely open. Only once you're past the suture line, you see here is the area where it was attached to the suture line. When you're past the suture line, then you're truly inside the external auditory canal. So we'll do that. And then let me see. Okay, this is a good instrument. Now I can continue forwards with an elevator and elevate this up as far as I want. Okay, so I'm going to keep this nice and elevated here. This is all tympanic bone now, so we want to keep this nice and deeply elevated. There. Good. And now we're working ourselves down the external auditory canal. Then we're going to elevate this up. This, I think there was some surgery done here, so this is why this detached. If it detaches, it's not a big deal, but I like to keep it intact before I do the drilling on the mastoid, so that the bone dust doesn't just go through the perforation and fill up the middle ear. There's a second suture line, okay, up here, tympanosquamous suture line. I want to do the same thing, and we want to feel that suture line. So here's the suture line, and I'm going to cut sharply. Sometimes you need to use a sharp blade or a beaver blade, a 6500 or 6400 beaver blade is very nice. But anyway, so we're going to detach this suture line as well, so that we can go nicely anteriorly. And then when we do finally open our ear canal, we're going to be nicely inside. Okay, but I'm going to leave that alone because I'm not going to be doing that today. Right there. Now that we have that set up, we can make a back cut back over here, and a nice single back cut like that is nice, so that we can expose the rest of the mastoid. Again, you can do it sharply, or you can do it with the monopolar. I like to do it with the monopolar so that the field is essentially bloodless. Not only is it nicer to work in a bloodless field, it also makes nicer videos. Okay, so we want to take this back like this. And then we also want to elevate this, okay? So let me see if I have a little better elevator, but I think I can use this. You can do this with a monopolar as well. Let's just see if we can take this up like this. Yeah, okay. This will be good. Let me just cut it and then cut it here and take it up. Good. So we want to expose this so that we're at the temporal line, and we can put a second retractor. Okay, so we can use one for the canal, like that, and then we can use a second retractor to keep this up. Now, I always place, it's a lot better, if you put your retractor like this is going to come up and over and be more of an obstruction. So it's better to put it underneath the first retractor. This isn't exactly the best retractor for this because it's a little long. I may switch these because this one is a little long. It's a different kind of retractor. So I'm going to switch these up so the retractor is not blocking my way. Okay, good. Take this here. Just clean this up a little bit. You know, you want to clean this tissue up before you start drilling, because imagine you're drilling and you're taking a nice sharp new burr and then you're going to drill it up against a piece of leather. And inevitably what's going to happen is you're going to quickly dull the burr. So getting this soft tissue off the bone is useful in that regard as well. Let's see here. Okay. All right. There. Good. So now I'll show you. Here's the drill. I prefer, personally, but again, like I said, this is my way, and other people have their own ways. I prefer a straight handpiece, and there's a reason for it. I also prefer my suction to be on the irrigation system, but we don't have those. That's more difficult to organize. Yeah, this is not really clipping, but okay, that broke. I broke it. So I'll do this. Watch. We'll take this and put this over here, and that'll work. And then I'll disconnect this from the line here. There. The reason I prefer straight handpieces in general is because there's only one mechanism in the handpiece to wear as a mechanical tool. When you have an angled handpiece, you have a second mechanism in there to convert the energy. And the straight handpieces, they just last longer in terms of practical use. I start mastoidectomy with a 5 or a 5.5, no bigger. The 6 and larger burrs, they have more tines and they're closer together, so they're actually less aggressive. When you get above 5, looking for my suction here, when you get above 5 millimeters, in general, you actually lose aggressiveness as a compromise for the increase in the size. I also, if you put the camera here for a second, I just want to show, look. So I'm holding my suction like this, and then it's okay, that's good like that. And then this part should be up against the patient's head, somewhere on the skull to stabilize. I see people drill like this, and this is not a good idea because you have no stability and you have no control. The other thing is this suction does not have a control hole, but your suction should have a control hole so that you can control the rate of suction. But no, that's okay. So now let me just see how this is working. I'm going to wait for the irrigation. Maybe give me a little bit of hand irrigation, okay? So the first thing I'm going to do, I'm just drawing a line here, okay? Right along here. I'm drawing a line around the temporal line here, okay? And then I'm drawing a line here. I usually do this with a marking pen. Here's the spine of Henle. It's not very well developed. Some people don't have a developed spine of Henle. So now I'm going to mark this. So this is the temporal line, and then this is the back of where I'm going to maintain the external auditory canal. And I reinforce that you want to mark that line early on in your dissection, because if you start somewhere back over here, it's just a kind of a tedious process to start marching it back to the place where you want to ultimately have it. So just do it at the beginning, and then you don't have to think anymore about the position of your incisions. So I'm going to start here, up at the top, and I'm going to make nice long strokes. Can you give me a little irrigation fluid? Yeah, it's good. It's coming now. Good. It's coming. So I'm going to make nice long strokes. This is not a new burr. Do we have a new burr, or if that's possible? This is kind of an old. It's kind of an old burr, so it's not there. So I'm coming here along the temporal line first. This patient has a very well pneumatized bone, so we're already into air cells, which is fine. So we're going to keep this up as high as we can get it. Yeah, let's see. It's okay. Yeah, I'll use this. I'll use this. That's okay. Let me just see if I can get this here. Okay. So I'll show you on the video a little more, because this is a very well pneumatized bone, so we're already clearly into the air cell system. Then we will come back this way and go right in the region where we marked to get the canal wall incision, right down towards the mastoid tip. Okay? Okay, so yeah, this is, let me take this off so that I'll take this off. There. You can see a lot better. So now we've got essentially an upper incision and this canal wall incision. At that point, we want to remove this cortical bone. Okay. Now, this is a very dull burr, and I'm sure that many of you in your centers have such burrs, but it is better to have a new burr. Let's see. So we can do it, though. So you wouldn't want to see this kind of burning, but it's okay because the patient's already dead. Now, it is okay to get this kind of heat and burning if you're trying to get hemostasis in bleeding bone, so long as you're not near any critical structures like the facial nerve. By having that kind of, we call it dry drilling, you can dry drill in order to accomplish a hemostatic effect from the heat. It's perfectly okay to do that, just not near the facial nerve. So now I'm going to look up in here. I'm going to take this edge up. Okay. I think I'll get this eventually. Here. So I'm going to be looking for the tegmen tympani. And in this very well pneumatized bone, it's going to be pretty obvious. It's going to be on the other side of these air cells. But we'll discuss after how to make that distinction in less pneumatized bone. I'm getting up to it right here. We're going to see we're getting to the dura. Taking nice long strokes, controlled strokes. Do we have a new 4-cutter now? I'll take the 4-cutter because this is not working very well. And I'll take a little hand irrigation. Where's the, yeah, thank you. All right, good. Okay. It's important to irrigate from time to time throughout your procedure just so that you can see what you're doing. You know, you don't want to have all of this stuff grinding it into the bone. Good, let's see. This is a 4 cutting burr. It's a long burr, so it's another issue. You want to try to use the shortest burrs possible, okay, in general. But I think this is going to work a little better because it's sharp. So now, okay, now I'm coming back this way, and here is the tegmen, all right? This patient may even have some natural dehiscences because of this extensive pneumatization. But you can see right here the dura, okay? Then we're going to take this up into the zygomatic root region. It's very important, a mastoidectomy doesn't have just this little shape here. It must extend above the external auditory canal as well. So all the way at the beginning, you want to make sure that your mastoidectomy is also going above the external auditory canal. It's a common error that amateurs make, is to work and stop their work around this area. So I'm going up over the top, and we'll identify the tegmen here. There, okay? Now, we want to get a nice view of the tegmen tympani all along here. Here it is. Okay, so now that we know where that is located, right, then we can start to work behind the canal wall. And you see, the advantage of opening the ear canal, again, imagine this wasn't disconnected, it would be stuck. You can still see nicely down the external auditory canal. So you'll be able to gauge where you are and not enter the ear canal, and yet still have it closed off. So I'm working nicely underneath the ear canal with controlled strokes. And if you're asking yourself the question, which you should be, how deep can I go? By looking down the ear canal at the level of the annulus, you know that you're well lateral to the lateral canal and the facial nerve. So all of this bone here is very freely removable, okay? So you just take this bone off. Now, many people instruct to find the sigmoid sinus at this stage. I'm going to tell you that it's not necessary. If you have to find the sigmoid sinus for purposes of the dissection, fine, then do it. But if you're doing either a cochlear implant or cholesteatoma where you don't intend to have a whole dissection, in a chronic ear you may have to eradicate all these air cells. But if you have healthy enough air cells here, you don't have to find the sigmoid sinus. You just have to know to work in this area in front of it, not to injure it. So we're just going to take a little bit more of this off like this and get this area opened up. And our first priority is to go through the Kerner's septum. And the Kerner's septum is right here. So I'm just going to make some strokes in this direction, just right here, centrally located. And there, I'm through the Kerner's septum. And the first thing I see there is the lateral semicircular canal. You have a curette. There's a curette here. I have it here. Yeah, here. Now, at some point, especially when you're less experienced, you may even want to explore this with a curette. There's nothing wrong with using a curette. A curette is a very safe tool, So just careful about curetting into the dura. But a curette is nice. You can use a curette from time to time. You want to say, okay, I want to confirm what I see. Curette will not go through the semicircular canal. So if you wanted to use a curette to examine, it's completely a reasonable thing to do. Okay, so I'll just show you. You can curette a little at this juncture, and then we'll curette again a little later. Now I see that I'm nicely through to the lateral semicircular canal through Kerner's septum. The next task will be to thin the canal wall, follow the dura, and then open up the epitympanum. Okay, so now I was working like this with the drill. I was making this kind of a triangle strokes. Now I'm going to change my strategy, and I'm going to go from in to out. But I don't want the burr to hide under view like this. Because if the burr hides under the view like this, I can easily drill something that I don't want to. So you should always see the burr, but move it from in to out, okay? And you can see down the canal wall as well. So we're going to thin the canal wall, and we're going to open the epitympanum at the same time. So I'm going to come into out like this, gently into out, just like that. Okay. Okay, and again. Now, if we're looking down the canal wall, it's very important. I'm going to show you this. I'm going to fill the canal wall I'm going to fill the canal with fluid, if we can, for a second. Yeah, actually, better I leave this alone. Let me see some fluid. I take it. So watch this. If I fill the canal with fluid, you see that as there's fluid in the canal, it gives the impression that the canal is further away. See? We're pretty open now, but see, as I put it in, the canal appears to be further away from me. So you have to suction the fluid out. That's called a parallax effect. You get parallax of the light. So when you have fluid in the canal, you can falsely believe that the canal is further away and enter it from behind. So you want to empty it of fluid with your suction, and then you want to watch. And you can watch right down the barrel of the canal, just like this, you know, and move along the ear canal, thinning it as we get closer and closer to the adductus, right? So again, I'm going to get it closer to the adductus, just like this. And then I can open this, because I see I'm well behind. Here's the lateral canal. The facial nerve is going to be about or just medial to the level of the lateral canal, so I can continue freely in this area, because I'm well lateral to the facial nerve here. Okay? A little here. This is the sinodural angle and the back angle. You want to open this up a bit. Again, notice I haven't definitively located the sigmoid sinus because it's absolutely not necessary at this point. You'll know by your CT scan if the patient with a chronic ear has a very small cavity and a very anterior sigmoid, you're going to know that you have to identify it at the beginning. But in this case, you do not need to do that. So I'm coming up a little more in the sinodural angle. And for a cochlear implant, you have to open up this sinodural angle a bit so that you can get your instruments in this trajectory for insertion of the device. So we can open this up. And notice something else. The burr is designed for a right-handed surgeon, and the tines are rotating. As you look at it like this, they're going in a clockwise fashion, which means on the bottom, they're going in this direction. So if you move your drill this way, you're getting the most efficient cut, okay? If you move it this way, you're just basically skimming the surface and a less efficient cut. Unless you're left-handed and you have no choice, it's better as a right-handed surgeon to think of a scooping manner like this. You see, like as if my hand is scooping the bone out. So in my mind, I'm a tiny little hand scooping bone out like this, okay? There are times when you scoop, and there are times when you use the burr for its own energy to remove things, and you imagine yourself to be a tiny little micromotor manipulator, like a robotic instrument, and you move the burr, letting the burr do the cutting, and you just control where it's placed. But in these earlier phases of the surgery, it's safest and more effective to scoop. And you scoop away from critical structures. So you twist your hand. Here, I'm scooping away from the dura, okay? And it becomes more pertinent when you start doing labyrinthectomies and these sorts of other procedures that you're scooping away from the facial nerve, away from structures. Here, so I can scoop this out, I can scoop this, and now I'm looking into these, what we call retrofacial air cells. I'm going to open this a little more here. Let's get some of this some of this soft tissue off. Now, okay, so let's open this up. Get this mastoid tip open. You notice this is actually bone marrow. Now, it looks different. On the live person, this would bleed. So it's okay to get this cleaned out. And we're going to use this as a landmark in a little bit later. So I'm going to show you, but just to get this cleaned out so we can see, okay? Just cut this again. Like I said, use You should use the electrocautery, sharp cutting, but I'm going to do it now like this because you will dull the burr faster, especially if you're reusing your burrs, which many of us are. So you don't want to dull them by drilling leather. Now, I've got the tip open. I've got here. Now, let's work now on the adductus, okay? And the first thing you're going to notice is that the shape of this starts to change. Here, as we get closer to the ossicles, this still has a bit of a curved appearance like this, okay? So it's kind of like a more even arch. As we go anterior and get to the region where the incus will be hidden underneath, this is going to start to tilt and look like more of an angle form coming off the roof, okay? So now let's go up under a little higher magnification and let's watch that happen. At this point, you would probably want to change to a 3-diamond. I will continue with this instrument just because it's very efficient, but changing to a 3-diamond would be very reasonable. So now watch, I'm still going to go in to out like this, and I'm going to unroof. Now I'm doing what I call the micro-manipulator. See, I'm letting the burr move in a trajectory as if it were a computer-controlled cutting tool, okay? So right here, this is very thin. Now look how, as I get closer to the incus, it starts to assume more of an angled view, okay? We're also seeing a critical structure. And the critical structure, which we did publish, is called the petrosquamous stalactite. The petrosquamous stalactite is right here. This ridge of bone, it's a little ridge. This patient has a very well pneumatized and even some dural dehiscences, but that's okay. This here is the petrosquamous stalactite. See this little ledge. This points you towards the, right here it is. This points you towards the incus. Okay, you can look up a publication that we have on it. It's a very consistent feature, and it even has varying attachments up over the ossicular heads, similar to the way an uncinate does. But it's right here, and it has a blood vessel that runs right through the center of it, right here. Okay, so this is it. Here it's not very well developed, but often it is a very sharply demarcated structure. Now, notice, as I mentioned, that this now looks like an angle rather than a dome, right? So now let's turn a little and take a look and see, do we see the incus yet? Well, we don't. That's okay. Now it would be completely reasonable if you wanted to use a curette. You know, you could take a curette and you could curette some of this bone until you saw the incus. That would be a very safe way to do it, see? Because the curette is not going to drill on the incus. You want to avoid direct drilling on the incus because that high-speed energy, very high energy, will be transmitted to the stapes and will cause a certain degree of sensorineural hearing loss. So, and the question is, did they remove the incus? They did, I think, right? So that's okay. We still have some nice landmarks here. But imagine there's an incus here, because I think it was removed in the last operation. I don't feel it. So I'll show you some films to show you that. Okay, so you also want to get to the point, there's still a malleus head here. Okay, good. So a complete mastoidectomy will really take you up over the top of the malleus head by going up through the anterior epitympanum, okay? And you want to be able to do that reliably and consistently. Again, I will use this, but I would probably be using a 3-diamond burr. I'm just going to take this off here, and then I'm going to put this up in here and just kind of come on this way. So now we're seeing this is the malleus underneath here, and now I'm just going to take this up so that I can see anterior to the malleus head. This is important, see, and I want to get some more. Here's the ear canal. I know I can thin this more. I put my suction in here to feel where it is, so I'm working at the limits of the ear canal without entering it, all right? And my hand is fixed. My drill hand also is fixed very firmly to the head. So I have total control over the instrument, all right? Even if it skips a little, now let's talk about that. Skipping is important. You see, it was skipping. Why was it skipping? It was skipping because this distance between the 2 points is not wide enough to accommodate the burr. So as it gets to this edge, it may just gently bounce off of this and then bounce the opposite direction. If you look at the way the tines are going, if you hit on the left, you're going to be pushed down. And if you hit on this side, you're going to be pushed up. So it'll end up skipping, all right? So that's very important to keep in mind. So what you do to prevent that is you work on one side only for a little bit. See, I'll open this up a little, concentrating on the left side. And now I'll work a little on the right side to get a view. See, so I get a little more view, and I'm not skipping anymore. Okay, and now that I have a big enough space, it's not going to skip as much. See? So now, there we are, okay? So we can see all the way up above. Let me see a little irrigation fluid. Good, okay, good. So you can see now that we're almost completely up to the level. We could even take a little more off here, you know, because a cholesteatoma would go up under this area and go up over an attic cholesteatoma, or pars flaccida cholesteatoma, would be up in this area. So probably I would switch over to a 2-diamond just to have a little better control and less skipping. But again, I'll do it with this. Okay, so you see that? Now we've gone completely up over the top. And then okay, there we are, see? So we're completely up over the top, and we can see completely over the top of the malleus, all right? Here's some, there's a cholesteatoma there, all right? Now, let's get that back. Now, let's talk about the facial nerve, all right? Let me come back out here. So the first thing we want to do when we find the facial nerve, see some handheld irrigation? Thank you. They made a cholesteatoma or the patient had one, I'm not sure, but it looks like a cholesteatoma. So, there are a couple of landmarks that are very important. One landmark is the lateral semicircular canal. We actually see the facial nerve here. Here's the horizontal facial nerve. Here is the cochleariform process and the tensor tympani tendon. Now, the facial nerve will come down. You see it's coming down a little medially. It will be medial to the highest level of the lateral canal, but it will ascend a little bit as it gets back over here, okay? So it's going to be right in this area somewhere, but there's a better way to find it than just isolatedly looking for it here. I advocate that you learn to open the mastoid tip. Here is marrow, here's the mastoid tip, and this patient has a very nicely developed landmark in this area. You want to look for the digastric tendon, little fibers that attach. The digastric tendon will go into the stylomastoid foramen. You're actually seeing it evolve right in this area. So as the digastric, and if you really want to try to find the digastric and you're a little confused or concerned, you can even take a burr and just open this up. Be a little careful in a small child, but in adults, it's no problem. You can just open this up and actually just see the muscle. You can see the digastric muscle under here to say, yeah, here, look at that. See, that's the muscle right here. So we want to expose the digastric ridge in the mastoid tip. And by exposing the digastric ridge and following it up to the stylomastoid foramen, we have one of the two very stable landmarks for the facial nerve. Okay, so let me zoom up a little bit. There. So, again, I would probably use a 5 cutter for a while and then a 4 diamond. That would be my drill of choice. Here's the muscle. You can actually see it right there. So we're going to open this up a little more. And let me focus us a little better. Maybe I'll come out. I think, yeah, that's a little better this way. So now I'm going to open this up and look for the little fibers, the white fibers. And here we can see here nicely, we can thin the canal wall. It's completely safe to do this. Take away any obstruction. I'm going to look. Now you see the marrow's gone away and we're into solid bone. That's what you're going to see first. First you're going to see the marrow disappear and the solid bone come up. And this is a very safe place to do it because the fascia around the stylomastoid foramen is thick, and it actually is one layer more lateral than the facial nerve itself. So here we're seeing this is the digastric ridge with the digastric muscle underneath. And this will come up to, we're starting to see them. So if you expose the bone there and you go through, you won't injure the facial nerve if you're careful because you actually have a little bit of a protective layer. See a little irrigation fluid? So here, you're beginning to see the fibers of the digastric ridge. Here they are. And it's very beautifully seen in this specimen. So we should really take a look at that. So now I'm going to just open them up a little more. You see these little white lines? These little white lines are the fibers of the digastric ridge. And they denote the position of the stylomastoid foramen. So the stylomastoid foramen is right here. So that's one landmark. So we know that the facial nerve is going to go here. The second landmark is going to be the lateral semicircular canal. Okay? So here's the lateral semicircular canal. So we're going to connect these two locations. Now, we still have a lot of material on the canal wall. So putting my suction here as a feeler and as a guide, I'm going to lower these cells up to the canal wall. And how do we know we're at the canal wall? Well, we can probe it with a little pick. Let me see, this is, I think, good enough. So we want a turn that we can see. And we want to feel it. And if we have this elevated, we can feel here, and we can feel along. So we can say, okay, yeah, here's the canal wall here. So we can actually look down both sides, and we could get this completely opened up. Here we have some more bone that can be removed. Here we have some more bone. Let's see. No, not so much. This is very thin already. Ah, yes, here. See, we can remove more bone here by picking out these air cells, all right? You want to pick out the contents of the air cells, the mucosal content of the air cells, so you can see through it. If you leave the mucosal content and then you start drilling it down with a diamond burr, you're going to create some white fibrous material, and it's going to become more difficult to differentiate that from the actual facial nerve. Okay, so now I know I can do a little more here. I'm just going to kind of thin that. And you want this completely down to the area of the canal wall. See, I'm perfectly safe here. Over here too, look. Okay, we're right there, okay? Now, let's come right down here and here. Yeah, I want to take a little bit more here. I can see here, so I'm safe. Very safe here. See a little irrigation fluid? Okay, good. Now I'm going to turn the head away a little bit. Now, I'll turn the microscope a little bit. There. So I'm looking right down the barrel of the ear canal. I see my end target here, the white fibers of the stylomastoid foramen, and I see here. Now, what do we have now? We have something that when I was training residents, I used to take their last name and call it according to their last name, because pretty much every resident does it. So when I had a Dr. Lim, I would call this the knuckle of Lim. When I had a Dr. Rust, and these are real names, by the way, it was the knuckle of Rust. Now, the reason this knuckle appears is because of a hesitancy and a fear of the facial nerve. But you must know that you must remove the knuckle before you're going to find the facial nerve. So let's just treat it as a, whether it's an actual anatomical structure, it is sort of a sculpted structure. So let's remove the knuckle now, okay? So we're going to take the knuckle down, and we're going to be perfectly safe so long as we don't go too deeply and beyond the level of the lateral canal. And there's another landmark that's going to come up here. It may still be here, hopefully. So I'm going to start like this and take the knuckle down, okay? Taking down the knuckle, looking carefully. So here, let's see here. Taking down the knuckle, and hopefully we'll see this structure if they haven't removed it yet. See, we're following along the canal wall still bone. See a little irrigation fluid? What I'm looking for, I see it, is the tendon of the short process of the incus, okay? This white structure right here is right here. This is the tendon of the short process of the incus. Okay, you see? The incutal fossa is here, and this is the tendon. It's always there. You can drill all the way up to and expose the tendon without hitting the incus, all right? So I look for that structure, and let's just leave it there. There it is. So that is the upper limit of where we can dissect without disrupting the ossicular chain, okay? Now let's look down here. Now I've removed the knuckle more or less. We can do a little more. Here is our digastric. Here are the white fibers. So we're basically going to connect this with this location right here. If there was an incus here, the incus would be kind of sitting here, and it would be pointing like this. And the incus is going to point to a spot here, and if we look at the curvature of the lateral semicircular canal, those two visual cues are going to end up right about here, and that's pretty consistent with where the facial nerve sits. So we've gotten rid of our knuckle, we have our inferior trajectory, and we're going to start looking for the facial nerve here. So now I will change. Do we have a diamond burr? I will start with a 4-diamond burr. If we have a 4, 4 is a very good size. If you use too small a burr, you're using, it's acting very much like a drill that you bought at a hardware store. You know, you can go right through into something if it's too small. So you want the burr to be as big as possible and still get the job. So what do we have? 3. Give me the 3. 3 is okay. 3 is acceptable. I prefer medium to coarse. There is a role for coarse diamonds, but when it's looking for the facial nerve, you're much better off with a 4 or a 3. Okay? Yeah. Thank you. And also short. This is good. So now, good. Good. So let me just do that one more time, because this is something that also has to be explained. You should know how your drill works. Okay? It's possible to seat the burr in incorrectly and still get it to spin in the motor. It's completely possible to do it. And you want to train your nurses to do it properly, and you want to check yourself. So you obviously make sure it's open. You place it in. These higher speed drill or newer generations of drills, they have a machined fixture to grab it. The older models, they just had a tension lock. Kind of the difference between using an impact hammer or a drill for a drill bit. So you want to seat it carefully. You want to feel it passing through the mechanism. Often there's a wearing of the ball bearings in the nose cone. So you want to first feel that it passes smoothly. If the ball bearing wearings wear out, the nose cone will tilt a little bit internally, and it will be a little difficult to get in. So that means you have to think about renewing and buying new nose cones. But when you get it in, it will pass through a little obstruction. And that obstruction, there, I did it twice. I felt it, and you want to align. This basically has a little slot, like a little screwdriver end. You have to align that properly into the receptacle inside. And you want to feel it go fully in. And the way you know it's incorrect, it's been introduced correctly, is when you lock it. Hold on. I can't see, sorry. Lock is this way. Yeah, when you lock it, this should freely spin. You see, now it freely moves. There's no friction. If you didn't put it in correctly and it was partially in, it will still grab it under tension, but you won't be able to freely spin it. And it'll still work for a while, and it'll heat up terribly. And that's how you know it's not in correctly. But first, before you even get to that point, you want to make sure it freely spins, right? It's very important if you want to maintain the life of your instruments, and you don't want to have your fingers catch on fire. Now, you're going to see this is, again, it's a little bit big. I'm going to try now again with the irrigation. Do we have that irrigation this one? Yeah, let's try this now. Because I really want to be under constant irrigation when looking for the facial nerve, okay? Because you don't want to heat the facial nerve. One mechanism of injury is heat. So let's see if we get this to work now. Yeah, okay, that's pretty good. I'm going to just adjust this up here. No, it's a baby boy. Look, there it is. No, it's okay. I just have to get it in the right place. You know, let's accept this. It's pretty good. Okay, look, now, you see that this is a little small, right? A little bigger, 4 would be perfect because it will cover a broader area. But here's our end, here's our beginning. So I'm going to take nice strokes like this, okay? And what I usually do is I think sort of mechanically, I think stroke, 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 suck, look. Stroke, 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 suck, look. Because, you know, you want to, underwater, you want to kind of be able to suck and look. And if you move it quickly like this, like a paintbrush, you're not blocking your view. If you go like this, see, you're blocking your view when you're like this, okay? So I think stroke, 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 look. Stroke, 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 look. And the suck is taking the some of the bone dust off, okay? So stroke, 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 look. Stroke, 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 look. Again, a slightly larger burr would be better, but it's okay. I can go a little back and forth with the diamond as long as I go quickly and I look. Quickly and I look. Okay, so now let's open that up a little bit. And I want to get a little better angle, so I want to see the whole canal wall. So I'm coming like this, okay? Down the barrel of the canal wall. But let's find the main facial nerve first, and then we can think about the chorda tympani. Let's see. There, that's better. So here are our fibers. Okay, let's go along the canal wall here. So stroke, 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 look. Stroke, 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 look. Now let's take a look, okay? Let's take a look. Here. So this is when we take a little pick. Let's see, do I have a pick? I think this is the pick here. And you start to take out, you see this white stuff, this is bone dust ground into the cells. So we want to remove that, you know, we want to kind of take that out, take a look at it, take this stuff out. You see right here, this is mucosa and bone dust ground into the cell, and we want to look. And it's here too. We want to get that out of there, okay? Get as much as you can. And notice that when I'm picking this stuff out, I'm not picking this way. Because if it happens to be that I've exposed the nerve and I go like this, I'm going to transect its fibers. If I go like this in the direction of the nerve, the worst I'll do is split the fibers and separate them from one another rather than trisect them. So you're going to do a lot less damage if you do it like that. So here we go. I'm going to take this stuff out, take this out. See? There we go. Okay, we're starting out this. What's this? It is just air cell, right? So now we can look a little more. Underwater, stroke, 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 and now I'm just sculpting it out because I see it's going to be right under here. Starting to see some pink. See something kind of pink there, so let's take a look here. This could be the chorda tympani here. I believe that is. This is a very well pneumatized bone, so sometimes you may see air cells lateral to your chorda tympani as well. So let's just delineate this a little better. Get this a little more open here. Let's go back to our pick. And, okay, this is a fish dissector. Here is a posterior tympanotomy cell that we're starting to see open up. Let's get this stuff out here. And we're seeing this is the facial nerve right here, okay? Just where we expected it to be. This is the chorda tympani nerve. Let me get the pick, it's easier. Where was the pick was? Okay, I'll use this here. So you see here, I'm going to pick some of this stuff out again, pick this out. A gentle curved pick or a rosin needle is best. I think I have a smaller pick here, do I? Yeah, this here. Here it is, I think it's here. No, this is a sickle knife. This will be okay, actually. So look, see? You want to get this stuff out to see it. Here, it's out, and you can see there's pink under here. This is the facial nerve is right under here. Let's look at that. This is either a cell or it's probably the nerve right there. You see that? So there's a little bit of exposure of the nerve within a cell. That's common, especially in a very well pneumatized bone. And we know. We can talk about facial nerve monitoring at a whole separate subject, but there. Okay, so that's nicely open. Now, what we're going to do is I'm going to open the facial recess. What time do we have? Just so I can see. 25 minutes more. Okay, good. So we have time. So the posterior tympanotomy is basically, I think of it, and I've always taught it as a 30, 60, 90 triangle. Okay, remember from geometry or algebra? I don't know. One of those two. Way long ago. So the 30, 60, 90. And I use that when I teach my doctors. It's just a matter of nomenclature. This is the 30, this is the thinnest angle, the 60 is the intermediate, and the 90 is the bigger. But let's just call it that so we know what we're talking about. And what we basically have is almost like a mini mastoidectomy. You know, we've got the ossicles here, we've got the sigmoid back here, and we've got this canal wall kind of thing is the chorda. But, you know, so we're going to use that nomenclature. And do we have a 2 diamond? Let me just see if this is. I can use this for a little while, but I will need a 2 or a 1.5. So I will go in for a while, and the safest place to open things is at the 60. So I'm going to progress the 60 all the way up to this tendon. This is the tendon of the incus, and I'm going to progress the 60 up to that area. So watch how safe, because we're not going to hit the facial nerve there. We're just going to work right in this area, just like we're looking for an antrum, a mini antrum. And we're going to go right up to this 60. See here, so I got all the way up to this 60. And the 3 diamond is perfect for this at the outset. Now we're going to thin this down. And look, how do I know I'm not going into the lateral semicircular canal? I know I'm not going into the lateral semicircular canal because I'm maintaining air cells on it. Just find my pick. Yeah, this is good, the sickle knife. So look, this white stuff, this is air cell, you see? Air cell, mucosa, all right? So long as you have a mucosa like this, you're not in the lateral semicircular canal. But once you stop having mucosa, you are in it. So here, we have a little bit of distance here we can go, but not much. This is pretty much the end. So right there, the end of the mucosa, here's the lateral canal. So we don't want to enter the lateral canal, and we do that by removing this mucosa here, okay? So now I'm going to go back to this 3. We still can use the 3. And now I'm going to follow the chorda tympani up to this area. So you're basically doing all of these things at the same time. Oh, what's that? Let's see, caught up there? Yeah. So you're doing these things kind of simultaneously. You're looking at these 3 structures, and you're trying to open them up. Let me fix my water. Here it is. Good. So, here I'm going to follow this up now. And I'm going to watch the other angle. I'm going to watch the top, watch the back for the facial nerve. We're going to follow this chorda tympani up towards the 60. The 60 is the first and safest place to be. And I'm going to take this all the way up until I'm at and even through to the incus tendon. Okay? Make this nice and smooth. And at this point, very small violation of the canal wall way medially, at the medial edge, it's not really a big deal if you're doing a chronic ear. Cochlear implant, you really want to avoid it, but if you're doing like a cholesteatoma where you're going to be putting in a graft or something, as you get down here, it's not a big deal. You don't have to get too excited about it. Here we see the facial nerve, and now I'm going to switch to a 2-diamond, okay? So I begin my posterior tympanotomy with a 3, and then I switch to a 2, a 1.5. Rarely you will need a 1 for very small work, but rarely. I felt it again. I felt it lock. I felt it lock, and I check it spin. So I'm not friction locked, so to speak. So now we're going to, here's the tendon here. I'm going to continue and follow. Here's my chorda. I'm going to take this up. And I'm going to open this up here. I think that's the end of the chorda. I think the chorda was there under the previous surgery. But I see it here. Here it is. And now, let me move this out of the way. So here we can go all the way up to where this incus tendon was. Look how nice a beautiful view we can get inside. Okay, here's the edge of the tympanic membrane. We would get to the annulus deeper, and we have nicely the posterior tympanotomy open. Now, I see the pink of the facial nerve. I'm going to stay just in front of it. Okay, just in front of it, and open this lower. Let me open this down a little bit, staying just anterior to the facial nerve, between the chorda tympani and the facial nerve. And look, this 2-diamond, this is pretty much the limit of a 2-diamond. So now we would go to a 1.5. Do we have a 1.5 diamond? If we don't, it's okay. But if we have it, it would be nice. And I'm just, again, working like a micromanipulator, staying in front of the nerve. Oh, sorry. Not letting it bounce around too much, keeping it in a nice controlled setting. Yeah, a 1. Okay, we'll use a 1. It's good. So now the 1. Great. The 1s tend to be a little bit longer, but that's actually okay, because they're a little tapered at the end, and that's actually okay. This one's not, but it's okay. We don't mind if it's a little longer on the 1, because then we're reaching a little further into the posterior tympanotomy. So yeah, it is a little longer. So now, we see very clearly, I could go to a smaller sucker, it doesn't matter right now, but here is the chorda tympani, here's the facial nerve. So at this point, we're just going to sculpt this open, reaching down and around the edge, around the bottom, and opening up the 30, okay? This is the 90. We've got that nicely opened. We can even open it a little more, even all the way to this. And now I'm going to open the 30, maximally open the 30 for complete posterior tympanotomy without sacrifice of the chorda. Okay, so we're going to do that. Take this off, a little bit of the bone here. This is the stapedius and the pyramidal eminence. We can see all that. When we go for that, we actually want to go up in size for the burr because we don't want the shaft of our burr to rub on the facial nerve. So when we go after things that are more deep within the posterior tympanotomy, we will go back up to a 2 or a 1.5, okay? So let's get this open. And now, this last piece, here's that tendon, right? The last piece is to open this up. And let's take a look now. You can do it very safely if you have intact ossicles with a curette. Okay? So, let me come out now a little bit and zoom just to show you. So it's perfectly acceptable to curette this away. You want to be careful, though, when you curette, not to go this way, boom, into the facial nerve, right? So, you know, you fix your hand nicely and you just twist and get this open like this, okay? And you curette this, especially when you're working right around the incus. If there's an intact incus, you really want to use the curette to get this open. You can work around the curette. You can push the incus down with the curette and then come up like this. So you would work the whole angle up, especially if you want to keep intact ossicles and you have a fairly limited attic cholesteatoma. You can keep the ossicles intact and work it out and around the ossicular chain by clearing the bone with the curette, okay? Last little bit like this. Good. So we pretty much have everything nicely done with a mastoidectomy. Posterior tympanotomy, facial nerve identification. So we have a little bit of time. I want to show a couple of videos. Yeah. Okay, so we have a little bit of time for some video. Yeah, here is good. Yeah. Things up here. No, that's all right. That's all right. I'll come back over here. CSF leak. What to do if you get a CSF leak? This film is from a surgery I did with a resident many years ago, and I answered a telephone call while I was supervising him, and I came back and I played back the video because I was recording everything in real time, and I'll show you what it's good enough. Yeah, thanks. I'll show you what I found. You can. Oh, I'm not on anymore on the thing. Okay. Okay. Good. So, let's take a look at this. So I'm going to show you how to repair an iatrogenic CSF leak. Let's move a little forward here. So here we go. Okay, so now, we're going to go back to that part here. So now watch very carefully. He's drilling now along the tegmen, and he will get some bleeding. And then he will continue to drill through bleeding. So here he's going, nicely going. You can see him here. He's drilling through. This is normal bleeding. I want to show you that for a second. You see, right here, you saw a little bit of bleeding. You're going to have solid outer table. Then you're going to have some marrow space in a less well pneumatized bone. And then you're going to have a thin inner table of the bone. And you may get some bleeding in between the two from bone marrow. And that's okay. But this was a little excessive bleeding. Now watch as this occurs. Here he goes. Here he goes. He sees a little bleeding here, right? That he should have stopped and looked at. But he didn't. He kept going, and going, and there it is. 1 and 2. Okay, so now we're going to see this. Remember, I'm on the telephone now, so now we're going to play it in a slow motion playback. And there he goes. Another, and boom. And there we're in. So you see some brain. Now, how do we fix that? The first thing you want to do is you want to look at it, inspect it, and stop any bleeding, because one of the worst things that can happen is an intracranial hemorrhage. So you want to stop the bleeding with a bipolar. Irrigate it, bipolar, get the bleeding under control. You can use some gel foam, you can use some Surgicel, whatever, but if you can stop it, it's nice. You know, get it stopped. Then here's a little Surgicel. All right, you want to inspect also the edges. So first we completed the disease removal, right? We completed the operation. So, you know, you don't want to stop your operation because of that. You want to finish your surgery and just pack it off. And so let's go through. We finished the operation. Here we go. So now we're going to go back to this, okay? So I'm going to get some fascia, and I'm going to take a little piece of bone here, okay? Because if it's bigger than about 1 centimeter, you should replace it with bone. This was just on the edge, so I decided to make a little bone plate anyway. So here, the back edge of the mastoid cavity is a good place to get a piece of bone. I'm going to show you how to sculpt this bone. What I do is I will take the bone in a forceps, and I will make a thin plate out of it. Okay, let's get this under control. I'm going to move a little head here. Good. So now you see I'm holding the bone in a clamp, and I'm going to thin the piece of it, except for the part that I have a clamp. I'm going to switch the clamp, and then I'm going to thin that part. So we have a nice thin piece of bone. Now let's look at this. Okay, we've got our bone plate. It's a pretty substantial hole. So you want to elevate the dura a little bit off the bone so that you don't want to put the bone intradurally. You want to put the bone extradurally, okay? And we're going to use some fascia and bone, and you're going to put it extradurally. So now we've got the dura elevated. Now, this is a little trick I have. You want to make a little control hole, not through and through, but just a little control hole. And why? You're going to see we're going to use this little indentation to slide the piece of bone into position. So first I take a piece of fascia, and we're going to put the fascia in on one side, in between the dura and the bone, right? And then we're going to use the bone plate to drive the fascia into position. You'll see it in a minute. And lock it in for a watertight closure. Even if you have to make the defect a little bigger to do it safely, it's perfectly acceptable to do that, all right? Now today we have taco seal. We didn't have that. Taco seal still would be insufficient because this is still a big defect. You can use cartilage. I like bone. So now look, I'm going to push the bone back, and you'll see that's going to push the fascia into position, snaps back. You want to make it as wide as the defect but longer. You see that now by using the control hole, I'm able to slide it forward. You see? So I was able to slide it forward, push it back, and slide it forward. So now you see you have a nice control of the CSF. If you want to rotate some muscle, if you want to do something else, probably today I wouldn't do any of this muscle. I would just put a nice piece of taco seal over it. Taco seal is a cellulose-based material, and it's watertight, and it's very nice. So this repair with a piece of taco seal over it would be perfectly adequate. Okay, so I wanted to show you that. How much time do we have left? Huh? 9 minutes. Okay, so let's take a look. What do we have here? Let's see. Oh, yeah, this is good. So let's show you some canalplasty, because this is also very important, and this is something that gets often overlooked in lectures. So this is a right ear. We made the Kerner's incision, and we're going to be going after something that's in the anterior superior quadrant. Okay, so here I'm elevating my Kerner's flap, making my incisions. This is a 6500 beaver blade. It's very nice. It's a mini 11 blade. I highly recommend getting access to this. And this patient has an anterior superior perforation, so I want to get the bone in the anterior superior region nicely exposed. So you see, I made my superior Kerner's incision, and we're going to elevate that, and we're going to remove all of the soft tissue and bone in the tympanosquamous suture line region in order to get optimal access. This is good for congenital cholesteatoma. It's good for anterior superior work, and it's excellent when you're doing attic cholesteatoma. So there's a lot of soft tissue up here. And you see here, this is a nicely developed anterior suture line. So I'm going to take, beginning with a 2 diamond, I'm going to take this. Now you can take this bone, you can make essentially a right angle square up here. You can go even into the temporomandibular joint, so long as you don't go grossly through the joint and expose fat. You can go very anteriorly. Look, here's the ear canal. Look how far. I'm going to go very anteriorly, and I'm going to limit this canalplasty just to the anterior superior aspect. I'm elevating this skin down, I'm following this down, and I'm going to track this all the way down to the annulus that's anterior to the malleolar attachment and the anterior malleolar ligament. All right? So I'm getting a huge volume expansion of this ear canal. Look how much work we get. Here's the annulus right here. This is the cartilaginous annulus. This is the anterior perforation. And we're going to get all of this exposed and all this bone removed to be able to work there. All right? So this is an anterior superior canalplasty. At that point, you can down elevate this tissue, you can cut this, and do whatever you need to do there. Okay? So that's a very useful trick. And then last thing I'll show you is a complete canalplasty. Here, okay, I have about 6-minute film, so let's watch this. Again, same side. Here is the anterior superior aspect. Now, I'm going to make an incision circumferential in this one because this is a large anterior perforation. So I want to work, I'm going to do a pull tab here afterwards to close this anterior perforation, but I want to get nice exposure of the anterior aspect. This is a 7200 or 7200 beaver blade. It's also a very, very nice blade. Excuse me. So I'm making now, elevating an anterior flap, complete circumferential incision. I'm going to lift this all the way up to the junction of the bony cartilaginous aspect of the external ear canal. And you notice I'm hugging the bone and feeling the point at which it falls up and over into the soft cartilage part so I don't tear this. All right, see? If you stay very close, stay on the bone, you'll be able to elevate this and separate the cartilage from the bone without tearing this flap. All right? Once you get it up to that aspect, you can use a strong elevator, a freer elevator, or something like this. See? Now here's a freer elevator, and I will now push and separate the cartilage from the bone to get a very nice exposure of the tympanic ring. Here we go. So this is all the bone that we're going to be able to remove. Here's the incision. You see, so a lot of bone can be removed. And why is that important? It's important because we're going to get stricturing and narrowing of the ear canal where we make incisions regardless. So we compensate for that by widening the ear canal. It makes for much better postoperative care and much easier to do the do the operation itself. So I'm going to take this down with a duckbill elevator all the way down to the cartilaginous annulus. And stay on the bone. If you stay on the bone when you're elevating these flaps, you won't tear the flaps. So you want to try to keep them intact. And it's a little bit blind, but we can feel the junction when we get to that bony cartilaginous annulus there, the cartilaginous annulus, because we're not coming off the bone. And then we'll eventually see it. All right, so here we want to come down. Inferiorly, there's a lot of blood vessels, so you will get to a point where there's some bleeding. And there you go. So now we can see the annulus, all right? And we want to remove all of this bone, all right? You're going to come down. You can see the annulus. Follow the annulus. And we can see now we've elevated the annulus back. And I use a piece of silicone. If you're using silicone for any other purpose, your piece that you have is more than big enough to use this. You can even use this silicone at the end for supporting your graft. But now I will begin with a 3 cutting burr and remove the gross part of the lateral aspect of the bone. This is right at the bony cartilaginous junction. You can work broadly with a 3 cutting burr. Here is that area where we did the anterior superior canaloplasty, all right? So keep working with a 3 cutting burr until you've gotten down pretty far like this, and then you're going to go in there with a diamond, okay? Because you want to also, before you start the anterior part, don't forget about an inferior canaloplasty. You can see here is the tympanomastoid suture line, and you're going to take down the tympanomastoid suture line pretty aggressively so you don't get inferior blunting. And now we're going to change our direction. We're going to work towards the anterosuperior aspect. And you will be able to see there's even a thin remnant of the suture line right here that you're going to follow this. Now I'm working with a 2 diamond burr, okay? And from time to time, you may want to come, take out your flaps, and then down elevate a little more, okay? Here we're following the annulus up, so we see exactly where the overhang is. We've exposed this area, and now we're going to put that back in. The silicone is very nice. If you don't have silicone or don't want to waste silicone, you can use a little piece of the suture packaging, the little bit of metal from the suture packaging. But with the silicone, you do prevent, if you touch the silicone, you're not going to transmit high energy to the malleus because you're working right near the malleus. So the silicone is a little safer. If you're working with the metal, you want to be very careful and you want to retract this down with your suction catheter so you don't conduct sound directly through the metal onto the malleus and cause a sensorineural hearing loss. So now we've got this down. We're bringing this all the way down. And you can see we've got a lot of opening now. We can see very nicely. And once we've got that, we make a decision. At some point, we're going to make an incision into the flap. Regardless of whether or not we need an incision, at some point, if you're going to need incisions, you make it. But if you don't need them, you still want to make a little incision so that you can split this flap out and lay this skin back down. All right? So there we go. That's a full canaloplasty. And I think that's it. We're good with time, and that's about it. Do we have facility to take questions or no? Okay, good. So you'll ask me your questions later. Thanks very much. I hope you enjoyed the show. All right, bye-bye.